Hello, and welcome back to another video with me, Michelle Fortier, a licensed clinical social worker in the state of Florida. Today, I'm going to be going over 3 different articles. This is going to be the 4th class for the 2nd week, and we're going to be going over 3 different articles that relate to the last chapter that we did. The first one is called The So-Called Borderline Patient: Etiology, Diagnosis, and Treatment, and it's written by Tramboli and Marshall. And it is a structural model proposing the 3 distinct etiologies meaning causes. And one of them is genetic constitutional deficits. The other one is a rapprochement, crisis arrest, and Oedipal trauma regression. And these 3 different distinct etiologies produce clinically comparable borderline presentations that require different treatment strategies. So basically, this article goes over how symptoms and disorders can look the same. And so in order to pick the correct intervention, we really have to know where this disorder is coming from. And I like this because in the last chapter, we learned that we can't look at things just categorical. We have to look at the totality and things on a dimensional, and this kind of reflects that. So the article asks, why do some borderline patients respond to treatment while others resist? They talk about there being this precedent of hysterical patients from this person named Zetzel, and some of these hysterical patients were treatable and other ones were not, and it really had to do with their developmental level rather than their surface symptoms. And the authors took that example and applied it to the borderline diagnosis. And this label describes a shared symptom picture, not a shared cause. Differences in treatment response reflect differences in the underlying cause and structural development of the person with borderline, not simply differences in technique. So there's 3 competing theories that these individuals put forward for causes of borderline personality disorder. One of them is constitution and genetics. There's an inherited temperament and a neurobiological vulnerability. The second is parenting and rapprochement, and there's failures during Mahler separation individuation stage. And then the third cause of BPD is early trauma, physical or sexual abuse, especially around the Oedipal period. And with this, I just want to make it clear, I am somebody that is not as familiar with psychoanalytic, psychodynamic interventions or thought patterns related to mental health issues and personality disorders. So this has been a learning curve for me. If I get something wrong and you have any pushback or questions, please leave them in the chat below so that way I know and I can correct things. So the 3 etiologies, 3 levels of borderline organization. The first one they call the low-level borderline. That one has a genetic or a constitutional deficit. They consider that one to be the most severe, and there's a lot of aggression. There's periodic disorganizing decompensation, ready propensity to violent acting out. So that is your level 1 borderline. Your level 2 is your mid-level borderline, and this is one that they call arrested development. So the rapprochement crisis is the point where a child is a toddler, and as a toddler they start going away from their parent, and as they go away from their parents, if they feel that there's a secure base, they will come back from that to that secure base. And so if that is not done during this rapprochement period, that's where it's thought that borderline personality disorder develops. The second is that there is high-level borderline, and this is where the person develops an ego, develops some sort of some ego development. However, there is some sort of trauma that occurs, and then because of that, they regress, and then they develop borderline personality disorder. So we want to match the technique to the structural level. So in type 1, it's to build basic ego structure, develop a rudimentary ego skills before relationship work is possible. You need to consider doing long-term therapy with a benign, consistently firm therapist. Teach affect identification beyond mere pleasure, displeasure. So be able to identify what people are thinking and feeling. External structuring, hospitalization when impulse control is overwhelmed. And the patient internalizes therapist modeled ego functioning. So the therapist acts as a role model for how to do things, how to be a person. The second one is type 2 mid-level, and this is where we solidify object constancy. The goal in this therapy is to help the patient tolerate separation without decompensating. And this one, we will maintain firm therapeutic structure alongside a strong working alliance, expect repetition of the rapprochement crisis in the transference. Consider anti-anxiety medication or brief hospitalization if there are acute separations, and facilitate relinquishing fusion with parts objects towards self-object consolidation. And part object and self-object, it comes from a specific type of psychodynamic theory. I want to say it comes from Kernberg, where there's instead of just like people, they call them objects. I'm really not sure why. I'm sure that there's some deep reason for it, but we go a little bit more about that in the next article. The next thing on here is type 3 is they consider the high-level borderline, and the high-level borderline has the best prognosis. It's a patient who can flourish in structure because these patients previously achieved a partial Oedipal resolution. They retain real ego strength. In a structured, accepting treatment milieu, they will likely improve in response to nearly any consistently applied legitimate therapeutic strategy. So basically, this level is you give them treatment, they're probably going to get better as long as it is consistently applied and it is a legitimate therapeutic strategy. The hidden danger of this level, though, is these patients can be mistaken for healthy, neurotically organized individuals. They remain vulnerable to renewed regression when confronted with direct reminders of their trauma, so the apparent ease of treatment can mask real fragility. So this is kind of where, as I'm reading that, what pops up for me is the kind of thought process that personality disorders, borderline personality disorder, has never really gone under severe or significant stress, that the symptoms can reappear. So from my perspective, from what I know and the way that I explain things to clients, is that we are looking for remission, not cure. There are some clinicians, there are some schools of thoughts that personality disorders can be cured. I just go with the remission, not cure for myself based on what I know. And the recommended treatment approaches for type 3 is DBT, dialectical behavior therapy, mindfulness-based cognitive therapy, mentalization-based treatment, and individual psychotherapy with a knowledgeable, skilled clinician. This study came out in 2020, which was before the good psychiatric management of borderline personality disorder. And I can imagine that would also go on this list. The clinical takeaway for this article is treating all borderline patients indiscriminately will be chaotic. You need to figure out, based on the etiology, what you see in front of you, about what intervention that you might need to do. And I also think it's helpful to discuss this with clients so that way they know what to expect and how long that they might get till they get remission or relief from their symptoms and what that might look like. So one label, 3 pathways. We look at the genetic constitutional deficit, the rapprochement arrest, and the Oedipal trauma regression all converge on similar surface symptoms. The second is the structure predicts prognosis. Prognosis tracks the etiology. Developmental deficit arrest or regression, not the symptom checklist. So what they're basically saying right here is it doesn't matter how many of the symptoms that a person checks off. That's not the important part. The important part is where they develop the BPD. The third thing is technique must match structure. Ego building, object constancy work, and trauma-focused approaches serve different patients, not one protocol for all. I found this article to be very interesting, and it mirrored some of what I see with some of my clients, where they look the same, and then you start working with them, and you start to recognize how different they are, and it really does come down to the etiology. Second article to go over is a theory of personality, is the temperament, attachment, mentalization. These people, Sigmund, Carteroid, and Mickey Congersliv, they were like, okay, let's make us a theory about personality. And they put together this one called the temperament, attachment, mentalization theory of personality and its disorders. And they say a new integrative theory proposing that personality emerges from 3 evolutionarily nested layers. We start with the temperament, we move to attachment, And then we move over to mentalizing, and they build from one each on top of the other, from nature, which is temperament, all the way to culture, which is our ability to mentalize. And the authors say, hey, why a new theory? And they say, well, you know what? Personality science has outgrown its theories. And they talk about a diagnosis-driven crisis. When the DSM-4 and the ICD-10 came up for revision, the field agreed on two different things. Most of the field, we still have holdouts. Categorical diagnosis of personality disorders is scientifically untenable, and personality is dimensional. But there was no unifying theory existed to build a revision on. So the DSM-5 stalled, and they put this little alternative model for personality disorders in the area for further research. But the ICD-11 settled for a pragmatic trait model with little underlying theory. So they're like, we know that this works. We don't know why. We're just going to throw it out there. Hello, ICD-11. There's fragmented knowledge that is unlinked. Trait models, psychodynamic theory, and social cognitive approaches each capture part of the picture, but were never conceptually integrated. DSM-5's alternative model gestures at self-psychology, mentalization, and emotion dysregulation without ever tying trait aspects to social cognition and relational competence. And our authors say that a new theory must be broad enough to include evolution, neuroscience, and culture. It also needs links its explanatory principles to each other intrinsically, uses measurable core components, and fourth, bridge normal and abnormal personality on one continuum. And our author said, bet, let's do this. And they said, what is a personality? And they said, personality is the unique variation in the individual of the evolutionary base foundation of human nature, as well as of attachment and self-reflective abilities. Personality is expressed as developing patterns of dispositional traits, characteristic adaptations, interpersonal relations, and integrative life stories that are complex and interwoven in cultural matrices and interpersonal contexts. So off to the left, we have evolution, where we start off. Darwin, the biological foundation shared with other species, is part of this personality. Then we move over to attachment, and we include ideas from Bowlby, bonds that mediate nature becoming culture. Then we go off to the right, and we have the self with Fonagy and Kohut, self-reflective mentalizing capacity. Then we go over to the structural model, three constituents built in evolutionary order. Temperament is a prerequisite for attachment. Attachment, in turn, is a prerequisite for mentalizing. Nature becomes culture through this chain. So the first is we have our temperament, nature, how we're born. These are hereditary, and they're evolution-based primary emotions and dispositions. They are present from birth as behavioral tendencies. So we are all born with a temperament. The second, then we have our attachment, which is our lived experience, and a specialized case of primary emotions in action. Our attachment is mainly shaped by intersubjective experience with caregivers and not necessarily our genes. Third is our mentalizing. Mentalizing self-consciousness and social cognition develops within attachment relationships, internalizes cultural codes. And so now we go over the temperament part with the 7 primary emotions found across all mammals. Each has a distinct brain circuitry, neurochemistry, and behavioral signature. People differ in their proclivity for each, so how much of each shows up for them. Seeking, which is anticipatory joy. It's the prime mover that drives exploration and reward. So some of us are seekers, and we really love the dopamine, or we have high dopamine systems. The second emotion that they talk about is fear, and this is an unpleasant emotion. It's avoidance driving. When we are afraid of something, we want to avoid it. We want to get away from it. And the brain circuitry that it involves is the amygdala and the PAG, the PAG. The fear can be reduced by GABAergic drugs. So we have these little GABA receptors in our brain that help with reducing our fear and our anxiety. And we can make GABA. It's really interesting. Or take GABA in. I forgot how it goes. Next is rage. Rage is another emotion. It's triggered by threat, blockage, or humiliation. It is not a Freudian drive. Sexual lust, another one. It's a primary motivator for survival of the species. It's understudied in personality disorder research. The next one is care. Care is a prerequisite for attachment. It's promoted by oxytocin and endogenous opioids. So people, in order to care, we have circuitry in our brain that allows us to care, and it has to do with our oxytocin in how we bond. Then there's separation distress. And we feel despair at loss, especially low threshold and borderline patients. So for some individuals, especially with BPD, they have they feel loss at a very low level. So it could be where somebody just goes to the store and they feel that acutely because of how they experience their primary emotion and their proclivity for the emotion of separation distress. Then we have the emotion of play. Play serves a socializing function. It teaches us limits, rules, and enough is enough. Two other ones that they add that they don't consider classic emotions is social dominance and conscientiousness. They're temperamental, but they're not considered classic emotions. So they show up as temperaments, but not in part of these 7 primary emotions. Constituent 2 is attachment, from distress signals to internal working models. This is considered an evolutionarily recent strategy. It emerged about 150 million years ago with mammals. Attachment ensures a limited number of offspring are cared for intensively. It depends on the infant's fear, separation, distress signals being met with the caregiver's care emotion. So it's kind of interesting because this is something that the 2 different systems need to interact with each other to have this attachment where an infant needs to send signals about fear and separation distress. They need to feel some type of way that they are being separated and give signals that they have that. And then there's also the caregiver's care signals that where the oxytocin works properly and they bond to the baby and they are triggered to care for the baby when they are noticing fear and separation distress from the baby. The internal working models boldly propose that early experience builds internal replicas of caregivers, later becoming the template for relationships. Unlike temperament, attachment's genetic loading is only modest. So attachment is not necessarily genetic, although there does seem to be a little bit of that. And that makes sense to me considering the oxytocin and the desire for separation distress. Categories are really dimensions. And instead of thinking of secure, dismissive, over-involved, and disorganized patterns as being, in a box where they're each separated, we're going to consider them to be dimensions. And that makes sense because the attachment shows up differently under different circumstances. It's not necessarily where somebody is always one way. It could be their predominant trait, but that doesn't mean that it's always that way. And why it matters clinically. Disorganized attachment strongly linked to personality disorder. Surfaces clearly in group therapy settings when you have a disorganized attachment. There's a paradigm shift. It used to be that they used to think that attachment wasn't that big of a deal, but now it is considered across all therapies and all interventions that attachment kind of matters. And it is beyond survival. Early attachment fosters not just physical survival, but the capacity to mentalize and trust others. So we need to be able to feel some sort of secure attachment in order to be able to feel like we can trust other people and be able to mentalize. From core consciousness to self-understanding. Mentalizing, and this is the constituent 3, is the ability to mentalize. Mentalizing is a prerequisite for self-consciousness, the capacity to understand that minds, yours and others, operate on their own psychological logic. So there's this kind of thing where young children and sometimes people with personality disorders, they have a really difficult time understanding that I have a different way of thinking and feeling. Like, take for instance, I had somebody today where I was happy and they made it about them, that I'm happy because they did something. And like, I have my own mind. There is also somebody that I used to work with where back in the day where she would have her thoughts. She had a really difficult time for whatever reason mentalizing me, and she would often take what she was thinking and feeling and ascribe it to me instead of really paying attention to what I might be thinking and feeling. It's very interesting. And that's understanding that people have their own minds based on their own experiences. And so they go over these from going from core consciousness Core consciousness is where this is for young infants. It goes for animals, all this other stuff. It's where we're really just paying attention to what's going on right now. We're not thinking about the past. We're not thinking about the future. We're just kind of taking in the information. Then we have our core self, and that's agency, emotional experience, temporal coherence, bodily demarcation, something to be thought about. Then we move over to self-consciousness. It's not there until about age 4 to 6. Narrative identity begins to form. We start telling ourselves stories about ourselves and our experiences. And experience gains shape via cultural signs and symbols. Then the last thing is explicit mentalizing, a cultural achievement built on implicit mentalizing, interpreting self and others as intentional agents with wishes and beliefs. Clinical application of this model, they give us 3 different personality disorders and how it might show up with the TAM. The borderline personality, there's a low threshold and high intensity of rage and separation distress, and there's difficulty with regulation. Attachment tends to be insecure. It's prototypically over-involved or disorganized. Then there's a lowered capacity and a risk of gross breakdowns for mentalizing when they're under stress, and there's epistemic mistrust. The clinical tragedy is rage proclivity increases the very risk of abandonment they fear most. So they're most afraid of being abandoned. They have that low threshold for separation distress, but then they also have the low threshold for rage. And then they start raging and then they lose people. And then they're like, oh my God, what happened right here? So like their worst fear comes true because of their rage. Next is the narcissistic personality disorder. With that one, the temperament is there's high social dominance and low care. So there's lower empathy, just potentially lower oxytocin. So the attachment is they tend to have a dismissive prototype, knows many people, but few intimate relationships. Mentalizing, cognitively oriented, pseudo-mentalizing. So they think that they're mentalizing, but they're really not. They have a poor grasp of own weak sides. Clinical tragedy is status seeking undermined by the empathy needed to sustain it. So the desire to have people look up to them and want to be around them and be involved with them. You need empathy to do that. You have to be able to step in other people's shoes, and their difficulty with empathy makes it where they can't sustain those relationships like they would like. And so there's a risk of depression and suicide. The last one is avoidant personality disorder. There's a low threshold for fear, so they often feel anxious and fearful, and they have high thresholds for seeking play and rage. They're just really not, it's not really part of their temperament. They're not out for seeking new experiences, new interactions. They're also not really interested in play. They have a hard time with that, and they don't really often feel emotions of rage. So with attachment, there's divergent findings associated with fear-driven avoidant behavior, though. The mentalizing, they self-devalue, they're self-devaluing implicit schemas. So they don't think very highly of themselves. There's poor affect consciousness. They're not really aware of what they're thinking and feeling. It's kind of aware, and they're not really aware of what other people might be thinking and feeling. So there's poor affect consciousness. The clinical tragedy is self-seen as inferior schema blocks the connection that would disconfirm it. So they think very, very low about themselves, and their ability to get a corrective experience, they won't go connect with people to get the disconfirming experience because they believe that they're going to be unliked. So they avoid any relationships or opportunities to actually learn that people might like them. Avoidant personality disorder, it's a hard one. How TAM relates to established approaches. So they talk about the 5-factor model. The strength is impressive empirical support, measurable, reliable, predicts life outcomes. The limitation 5-factor is it is a top-down lexical statistical model, not a comprehensive theory. Presupposes a self rather than explaining it. The next one is the social cognitive theory about personality. And the strength is it captures dynamic idiographic aspects, how personality is expressed via causal structures and functions. The limitation is less concerned with how personality can be broadly described. Narrower nomothetic reach than trait models. Psychoanalytic. The strength is it persistently accounts for unconscious relational needs, conflicts, offenses, and the transference. The limitation is there's no single canonized theory today. Classical drive theory sits uneasily with modern attachment and mentalizing research. I'm not a big psychoanalytic, although I'm hearing that, it's making a comeback. Don't call it a comeback. Conclusion, a theoretical web from nature to culture. Evolution of temperament, lived attachment experience, goes to internalized culture and self-consciousness. So they talk about how personality is not just one thing, it is a web of three intrinsically linked constituents, each building on the one before. The theory has direct clinical reach. Personality disorders can be read as distinctive constellations of temperament, attachment, and mentalizing impairments, informing case formulation and treatment choice. It bridges nature and culture. Tame aims to dissolve the old opposition between natural science and hermeneutic. I can never say this word. That word, hermeneutics, by tracing self-consciousness back to its evolutionary roots. I even circled that word in the paper because I was like, how the hell do you say that word? And I still don't know how to say it. Oh, damn. All right. Every constituent is measurable. ANPS for temperament, ECR for attachment, and the RFQ for mentalizing make the theory usable in both research and routine clinical practice. Now, on to the last article. This one is three-dimensional approaches to personality disorders, personality functioning, personality structure, and personality organization. This one is written by Suzanne Hortz-Sagstetter, Ludwig Oss, and Leonie Campe. And it comes from the current psychiatry reports and published in 2021. This article is a review comparing three-dimensional theory-informed alternatives to categorical personality disorder diagnosis and what current evidence says about their overlap, differences, and clinical use. Bam. All right, why move beyond categories? The case against categorical diagnosis. There is a 40-year assumption that is under strain. DSM and ICD-10, the ICD-11 doesn't, but the ICD-10 classify personality disorders as categorical, qualitatively distinct entities. So we put these personalities, you have BPD, you have NPD, you have OCPD, you have schizotypal, you have schizoid. Those are categories. And decades of research now suggest personality disorders are dimensional. They sit on a continuum from well-functioning to highly dysfunctional and not in these discrete boxes. Now, there's two structural flaws from the categorical diagnosis. The first is that there's very high comorbidity between personality diagnoses. There's a lot of times, and I find this in my own work, I find it interesting that there are other providers, maybe they're better at this than me, I don't know, or maybe they just, I don't know. I find it difficult when I have somebody where I see them and they check off the boxes for one disorder, and then I'm working with them, and then I'm uncovering things from another personality disorder. And the research bears this out to be true, that a lot of individuals don't meet criteria for just one personality disorder. They often meet criteria for more than one, or they'll meet traits from different disorders, and they never meet traits for all of them. They have a personality disorder, but not one that's named. And then there's also high heterogeneity within them. So what that means is I can have somebody that has the disorder of borderline personality disorder, but there's so many different amalgams of what that disorder can look like because there's so many different traits that show up. So you can have somebody that looks like one disorder and one you can have it where there is one disorder where they're having these different traits. Like you can have somebody with BPD that does self-harm, that does have the black and white thinking, that has reckless behavior, that has these large emotions. And then you have somebody else that can just have some of those and have the dissociation. So not everybody in the disorder looks the same, and that's what they mean by high heterogeneity within them, cast doubt on treating personality disorders as separate constructs, hindering both research progress and clinical utility. The response is the alternative model for personality disorders, the AMPT, is the proposed impairment in personality functioning, criterion A, plus pathological traits, criterion B, though is not ultimately not adopted as the official classification at this time. However, I do firmly believe it'd probably be in the DSM-6. And they're changing the name of the DSM. This is going to be interesting. Anyway, three-dimensional lenses. There's personality functioning, and that's the AMPed criterion A, the new theory-informed synthesis. We have personality structure. It's rooted in psychodynamic theory, and that's the OPD. Then we have personality organization, rooted directly in Kernberg's object relations theory. The three concepts, a shared goal, three different routes. Off to the left, excuse me, we have from 1996 to 2008, personality structure, operationalized psychodynamic diagnostics, OPD. Broad psychodynamic framework, availability of mental functions for the regulation of the self and its relationships to internal and external objects, assessed via 8 domains on the OPD LSIA. In 1967, we have Kernberg's object relations theory for personality organization. It's directly theory-based, and there are the three different levels, the normal, neurotic, borderline, and psychotic, assessed via identity, defenses, reality testing, and more. 2011, we have the personality functioning, and it's the alternative DSM-5 model, the AMPed. Theory-informed synthesis, 4 domains, identity, self-direction, empathy, intimacy across 5 levels of impairment, 0 to 4, and it is criterion A of the AMPs. Okay, the levels of personality functioning scale, the LPFS, criterion A of the AMPed. A moderate or greater impairment is a level 2 or above, is the essential requirement for diagnosing a PD. However, there's a little asterisk, criterion A threshold in the AMPed, though one study suggests 1.5 may be a better match a DSM for personality disorder diagnosis. So right now they're saying you have to be at a 2. However, there is one study that suggests 1.5 might be better. Anyway, these are the 4 different ones. We have identity. These are the 4 different levels of personality functioning. Identity, sense of self, self-esteem, emotional range, and regulation. Then we have self-direction, goal setting, standards of behavior, self-reflection. Then we have empathy. And so they group these together. So identity and self-direction have to do with the self. Empathy and intimacy have to do with others. So a healthy personality, there is the ability to be flexible and have these traits for self and also for interpersonal. And when there's difficulties in these, that's when we have a personality disorder. So interpersonal empathy, understanding others' perspectives and motivations. Intimacy is depth, duration, and mutuality of close relationships. 5 levels of impairment. 0 is there's 0 impairment, nothing. You're easy breezy, lemon squeezy, no personality disorder at all, healthy. All the way to extreme, which is number 4. Personality disorders show up at 2 when we're using the AMPed. 1, you could still be kind of a little messed up, have some traits going on, but you ain't personality disordered. You're able to be flexible when you need to. You can have relationships. Sometimes you might be on the struggle bus, but nothing so much that it impairs your life. And clinical relevance, not tied to one theoretical school, accessible across treatment modalities. The LPFS is relatively easy to learn, and experienced students applied it acceptably in multiple studies. It substantially shaped the ICD-11 severity rating of personality pathology. So the cool part about using the AMPed and the levels of personality functioning scale is you don't have to be really trained up in one particular theoretical school, which is great for me because I really like DBT and MBT, and I am not very psychodynamically or psychoanalytically trained. Just not my jam. And speaking of psychodynamic diagnostics, rooted in Freud's structural model and developed through decades of psychoanalytic theory, assessed via the OPD levels of structural integration access. So they have these 8 different ones: self-perception, internal communication, object perception, communication with the external world, self-regulation, attachment to internal objects, regulation of object relationship, and attachment to external objects. There's 4 levels of structural integration: high, moderate, low, or disintegrated. Clinical relevance, cluster B patients, histrionic, narcissistic, borderline, antisocial, show significantly lower structural levels than cluster C. The avoidant, dependent, obsessive, compulsive. The OPD LSIA can define therapy goals and plan treatment strategies. Structural change itself can be tracked with the Heidelberg Structural Change Scale. Then we have concept 3 with Kernberg's object relations model, a continuum from normal to psychotic functioning assessed across identity, defense mechanisms, and reality testing. We have the normal, neurotic. There's an integrated identity, mostly mature defense mechanisms, and stable reality testing. Then in the middle, we have borderline, and that's the border between normal and psychotic. There's impaired identity, mostly primitive defenses, so there's splitting and projection. There's fluctuating reality testing difficulties. This is a threshold for severe personality disorders. Then you have all the way to the right, PPO, the psychotic. Suspension of reality testing is the core defining feature. Assessment domains is identity, object relations, primitive defenses, reality testing, aggression, coping and rigidity, and moral values. Clinical relevance is higher levels of personality organization predict better treatment outcome. Low BPO and PPO predict dropout, therapist countertransference strain, and weaker alliance. This framework underlies transference-focused psychotherapy, TFP. And TFP is another type of intervention for personality disorders. Comparing them side by side. Categorical PDs, the good old categories, BPD, NPD, blah, blah, blah. First came about in 1980 with the DSM-3. The classification is categorical, 10 entities. It's theoretical. The key interviews are the SCID-5 PD and the SCID-5 SPQ are the key questionnaires. Personality functioning, we got the 2011. We started with the AMP, the Alternative Model for Personality Disorders. There's dimensional, there's 5 different levels. It's theory informed. There's the SCID 5 amped 1 and the STIP 5.1. I'm going to make a plea to the APA. When I went to go buy the SCID to be able to do amped interviews and amped evaluations, those things are expensive. And you have to buy like the clinical guide, you have to buy 1, you have to buy 2, 3, and they're like $80 each. You're looking at a lot of money. So what I did is I bought this one book, and I'm going to try to see if I can figure it out from this one book. You don't have to use those interviews in order to diagnose. It makes it easier, but my goodness, like almost $400. I'm going to try this book first. It gives it, and like they said, you can do the dimensional. They gave it to early clinical workers, and they were able to figure it out. So anyway, key questionnaires, LBFS-BF, LPFS-SR. Then we have the personality structure from 1996, the OPD, dimensional, 4 levels, it's theory framed, and we have our key interviews or key questionnaires. Our personality organization comes from object relations from good old Kernberg in 1967. It's dimensional, 3 levels, theory-based, STE, IPO, SI, and the IPO BPI. Convergence and divergence. They're related, but not interchangeable. A recent factor analytic study suggests all 3 concepts share a strong common factor, and numerous studies confirm high convergence between each pair. Interviews for one concept have been used to successfully extrapolate scores for another. So functioning versus organization, identity, primitive defenses, aggression and reality testing, organization, uniquely predicted suicide attempts beyond overall functioning. Empathy, functioning, uniquely predicted diagnostic severity beyond overall organization. Then we have functioning versus structure. Some structures, subdomains, bodily self, affect, communication, use of introjects may not be sufficiently captured by the personality functioning concept. Bottom line, the 3 concepts are empirically related, but each may carry unique facets that complement the others. The choice of instrument still matters. Clinical instrument illustration. One patient through 3 diagnostic lenses. A 26-year-old man presents for treatment after a breakup with depressive symptoms, suicidal ideas, and anger at an unfair world. If we use the SCID-5 and we interview this person as categorical, no specific DSM-4 personality disorder met the threshold. There were sub-threshold schizoid, paranoid, borderline, and obsessive-compulsive features, easy to die, symptom-based questions. And so when you're doing the categorical, I've had the experience where I've used it, and I had a client where his interpretation of the questions led, because I'd been working with him for years, and I was like, no, you totally do this, dude. Like, what are you talking about? And then we talked about like how he interpreted the question. And I was like, oh, that's not how the question is meant. You do this. And he's like, oh, my bad. I do. And it's not even just like a subjective thing. Objectively, he would be doing those things. And I'd be like, remember you did this? And he'd go, oh, yeah, that's right. So that is a problem with the SCID. And as this one says, is like The person had issues. He met different criteria for different disorders, but not enough to actually get the diagnosis. Then you have the STIPO, the organization, borderline personality organization 1, moderate impairment. So reduced self-esteem, sense of entitlement, primitive defenses, there's splitting, grandiose fantasy, and there's exploitative relationships. Then we have the SKID 5, the AMPT, the alternative model for personality disorders, functioning, overall level 2, moderate impairment, meeting criterion A. Impaired identity coherence, poor self-direction insight, reduced empathic reflection, and shallow intimacy. The categorical interview alone missed what the two-dimensional interviews revealed. Significant impairment in self and interpersonal functioning that shaped a concrete, structurally informed treatment plan. Because the purpose of diagnosing the personality disorders is to get an appropriate treatment plan to alleviate suffering and help somebody live their best life. Conclusion: 3 lenses, 1 shared foundation. Choose the concept that matches your clinical model, not one that replaces the others. So basically, pick the concept that works for what you do, your clinical model. All 3 of them are empirically well supported. They know what they're talking about. There's strong reliability, convergent validity, and clinical utility, each with multiple validated interviews and questionnaires. The choice, what you use, is really dependent on your framework. Personality functioning suits non-psychodynamic settings. That's me. I'm non-psychodynamic. Structure and organization fit psychodynamic case conceptualizations and treatments like transference-focused therapy, psychotherapy. Dimensional adds what categorical misses. The case vignette shows a patient who failed every categorical personality disorder threshold, yet showed clear treatment-relevant impairment on both dimensional interviews. And the fourth takeaway from this is more research is still needed. Evidence for dimensional advantages over categorical diagnosis is promising, but not yet sufficient to draw definitive conclusions. I hope that you found this review of these 3 articles helpful and informative. I am going to give this disclaimer. Some of the stuff is very new to me. I am very familiar with DBT. I'm learning a lot of MBT, and I know some schema. I am not really fluent in psychodynamic, TFP, those type of interventions, psychoanalytic. So this is kind of new language for me. Once again, feedback, questions, concerns. If you feel like I got something wrong, please put it in the chat below. If you find this information to be helpful and you think it might be helpful for other people, please share, like it, subscribe, and interact. Ask any questions down below. See you in the next video.